Good morning, everyone. I think there's a lot of traffic out there today, so we were trying to wait for everybody to get here, but I think we're just going to go ahead and get started. So I have the honor of introducing Rachel Rome, who, as most of you know, is one of our palliative care fellows. Rachel grew up in Tampa, Florida, and received her bachelor's degree and medical degree from Brown University through the program in liberal medical education. She completed her internal medicine residency at Brown, where she further explored her passion for palliative care and oncology. She is one of our palliative care fellows this year and is applying to do an oncology fellowship. So welcome, Rachel.
Good morning. Thank you, Kathleen, for the introduction, and thank you all for being here. Today, I'll be talking about caring for caregivers, using our communication skills to ease the burden. One of the reasons I love palliative care is that we get to improve the experience, not just for our patients with serious illnesses, but also for their family members and caregivers. Encounters with caregivers that I've had this year as a fellow that went well, and ones that were more challenging, got me thinking about how we communicate with our patients, caregivers, and family members. I started to think more about if we could use the amazing skills I've seen and learned this year with the caregivers we interact with on a regular basis, and if that could help ease some of their stressors and burdens. I have no disclosures. My objectives today are to describe the caregiver population we work with and the impact of emotional stress, to distinguish what information caregivers want and how they want to receive that information, and to consider how we can use our communication skills to relieve stress from caregivers. To achieve these objectives, we'll look at caregivers and stress, caregiver roles, and specific communication techniques, and general communication techniques. There are 34.2 million Americans who provide care to people aged 50 or older. The average age of these caregivers is 49 years old, and 34% are over the age of 65. And 1/3 of caregivers over 65 report their health being fair or poor. A vast majority of caregivers care for a relative, 85%. And down at the bottom of this table is the remaining 15% who care for a non-relative, friend, or neighbor. 42% care for a parent, 14% for a child, 12% for a spouse or partner, and 7% each for a parent-in-law, grandparent, or grandparent-in-law. I'll note here that for the remainder of this presentation, I'll be using the terms caregiver and family member somewhat interchangeably, in that families often serve as the primary caregivers and are often the major source of support to the dying person. Caregiving is not a short-term position. 50% of caregivers care for a loved one for more than 1 year, and 24% for more than 5 years. And the average duration of a caregiver's role is 4 years. Caregivers perform many basic tasks. 96% of caregivers help with ADLs or IADLs. On average, caregivers assist with 2 out of 6 ADLs, most commonly getting in and out of beds and chairs, and 4 out of 7 IADLs, most commonly grocery or other shopping, transportation, and housework. Additionally, 46% of caregivers perform medical and nursing tasks despite feeling inadequately prepared to do so. Caregivers report holding significant decision-making authority. They report monitoring the patient's condition and adjusting care, communicating with healthcare professionals, and acting as an advocate for the patient with care providers, community services, and government agencies. And caregiving is emotionally stressful. The proportion of caregivers reporting high emotional stress rises in relation to care duration, performing medical or nursing tasks, caring for a spouse or parent, burden of care, and perceived lack of choice in taking on their caregiving role. If you recall, 50% of caregivers have an extended care duration, defined as greater than 1 year, 46% perform medical and nursing tasks, and 54% care for a spouse or parent. And similarly, data shows that 46% of caregivers report a high burden of care, and 53% perceive a lack of choice in taking on the caregiving role. So we can assume that half, if not a majority of the caregivers we interact with are having an emotionally stressful caregiving experience. Caregivers who are more likely to want to learn more about making end-of-life decisions are older than 75, caring for someone age 65 or older, or caring for someone with a long-term condition. And I think that the caregivers we commonly interact with fall into at least the third box of caring for someone with a long-term condition. As I mentioned at the beginning, I have had many interactions with caregivers and family members that went well, and a few that were more challenging. We have all encountered challenging situations with patients and caregivers, and I invite you to take a second to think about a case or two that involved a challenging caregiver. For me, there's one case in particular at the beginning of my fellowship that got me thinking about how we communicate with family members and caregivers. The patient was a 90-year-old man with dementia and recurrent aspiration who presented with cough and hypoxia, found to have another episode of aspiration pneumonia. He was taken care of at home by his son and daughter. We were consulted for help determining his goals and values and figuring out a plan in line with those goals. We saw the patient when he was alone in his room, and we assessed his orientation, understanding, and symptoms. He was not oriented, and it was clear his dementia was such that he didn't understand what was going on with his health. His primary team organized a family meeting with his two children who we had not met prior. They were both immediately skeptical and nervous as the meeting began, and the primary team started by asking orientation questions in an attempt to demonstrate the patient's degree of dementia. His son started getting angry and upset, saying we weren't giving the patient enough time to answer, and we were confusing the patient because of all the people in the room. As we started to explain that the patient's dementia and aspiration were worsening, his son got more and more upset and angry, and eventually stormed out of the room, saying he didn't want to hear this, and that he couldn't believe we would do this to an old man. He refused to return to the meeting or to hear us out after we followed him out of the room. Afterwards, I thought, is there a way that we could have helped this family member receive the information we were trying to provide? Could we have better prepared him or presented the information differently? There is limited literature on how caregivers want to receive information. So I'll describe two frameworks from qualitative studies that can help us stratify caregivers into roles. There will certainly be caregivers we interact with who will not fall into these frameworks, but it is a good starting point. First, I'll present a qualitative study from Sweden with interviews of 20 family members of patients with incurable progressive cancer on home hospice about their experience learning that there were no further cancer-directed therapies being offered. The interviews were done within 3 months of the Breaking Bad News conversation. They found that caregivers take on roles to help and to protect the patient. They described prominent roles, further delineated into demander of truth, secret keeper, and controller. These roles come with an expectation that the caregiver takes over in terms of communication. And they described background roles, delineated into surrendering, considerate listener, and excluded outsider. These roles come with an expectation that the caregiver be present but with restrictions. These roles provide a framework for how caregivers perceive their role, whether consciously or subconsciously. Again, as we go through the descriptions of these roles, think about caregivers you've interacted with and see if any of these descriptions resonate. Prominent roles seem to coincide with an implicit or explicit deal between the caregiver and the patient, or between the caregiver and the clinician, that the caregiver should speak on behalf of the patient and communicate with the clinician. The first role described is the demander of truth. I think I asked so many questions that the doctor herself had to go and ask whether there wasn't something else that could be done. In this role, information is demanded, sometimes with an aggressive intonation. They feel like information is extracted from a clinician. This behavior is felt to be an aid for the caregiver in testing the clinician's competence, and in so doing, testing the truth of the information. The secret keeper. The doctor and I agreed about not telling my husband anything. We totally agreed, and even the children agreed, because it's best. The secret keeper wants to have all of the information without letting the patient know. This person creates an alliance between him or herself and the clinician and other relatives. In the study, they found that in previous visits in which the doctor had given warnings about the progress of the disease, these warnings were silenced with positive words and by telling the patient that this was simply a misinterpretation of the situation. It is important for the secret keeper to protect both the patient and him or herself from unpleasant thoughts and discussions. The controller. The doctors talk to me instead. Not all the time, but very often. I have to watch the words I use. But it's not because I want to hide the truth, because gradually he'll learn the truth when I see that he can take it. The controller is a kind of stand-in who communicates with the clinician instead of having the patient do so. By being active in the dialogue with the clinician, it is possible to control some of the information. Protection of the patient is the main aim, not for the purpose of eliminating the information, but rather so they can deliver it themselves in small portions when they judge the patient is ready for it. Returning to the expectations caregivers feel in these prominent roles, they feel they are expected to be strong and capable because they are not the one dying, and they feel pressure to be able to handle the situation. It can be very stressful for caregivers to live up to these expectations. Background roles seem to coincide with the patient's or clinician's expectation, as perceived by the caregiver, that they should be present, but with restrictions in asking questions or expressing feelings. The first role described is the surrendering role. I tried to harden myself, but then it came to a point that only one word was needed to knock down all my resistance to being weak. I totally collapsed and they had to take me out of the room. Central to the perception of the surrendering role is loss of emotional control and supportive function. They feel like their presence is the only thing they can contribute. Some of these caregivers described feeling that they had lost their power and their self-control, and that it was difficult to be supportive while experiencing such chaotic feelings. The considerate listener. You have to stay in the background, and I really had to make an effort not to ask the questions I had. I'm not the one who should make any decisions. I'm not the patient. The considerate listener describes him or herself as being present in the background as a silent support. Their role is to be there for the patient and to listen to the information provided. Considerate listeners do not want to bother or trouble the clinician, nor do they want to hurt the patient with their own questions. Instead, they conceal their thoughts and feelings. And the excluded outsider. They had never said her cancer was incurable. I didn't understand it that way, and no one had explicitly told me about it either. For 1.5 years, I've lived with her and see how she has become more and more broken down. Central to the perception of the excluded outsider is loss of role function, rejection, and disappointment. This caregiver has not received enough honest information about the seriousness of the illness. The truth has been kept from him or her. Those in this role have to ask for and receive this information alone, as the patient already knows and probably has known for some time. These caregivers are very disappointed and angry, both because of the bad news and because of their involuntary position as an excluded outsider. We'll return to these roles, but now I'd like to describe another framework. This is from a qualitative study from California of 20 caregivers of lung cancer patients seen at an outpatient oncology clinic. They highlight 4 caregiver roles that relate to their hypothesis that family rules govern appropriate topics and frequency of discussion, dividing along an axis of comfort with difficult conversations. They describe 2 roles that are less comfortable with difficult conversations, carrier and lone, and 2 roles that are more comfortable with difficult conversations, manager and partner, and how caregiver stress and self-care manifests in different ways. We'll start with the carrier role, which was considered to be a role that is less comfortable with difficult conversations. She's always done everything for me, and now I should step up and do a little bit more. I say to myself, well, I know she's stressed. I know she's feeling that she has no control. She's not comfortable in her body right now. Carrier caregivers underscore their strength and ability to handle caregiving, repeatedly pointing out that they are capable of handling the patient's psychological stress. Carriers deflect to the patient and undermine their own struggles and stress to focus on the patient. They rely on the patient to make care decisions, and they assume all caregiving tasks for the family. Emphasis is placed on the vital role of the patient in the caregiver's life, giving a rationale for why the caregiver will not talk about caregiving stress. Explanations for the patient's feelings and empathy for the patient's illness are frequent topics for the carrier caregiver and are used to prioritize quality patient care over caregiver self-care. The lone role is another caregiver role that is less comfortable with difficult conversations. I have no support from the family. Nobody cares. It's like the family tries to stay away from his problem. If it is related to medical or his treatment, I tell him everything, but everything else I just keep to myself. In addition to caregiving tasks, the lone caregiver experiences increased stress as he or she struggles to understand why other family members do not want to be involved in the care of the patient. The caregiver typically focuses on the physical aspects of care and has trouble considering a more holistic approach to care. Despite low amounts of conversation with other family members, the lone caregiver and patient share communication about disease and treatment decisions. However, they focus only on discussions about treatment and avoid quality of life topics. Lone caregivers have difficulty understanding healthcare providers, lowering their communication confidence, and restricting the topics that they are comfortable talking about with the patient. Moving on to the caregiver roles that are more comfortable with difficult conversations, we'll first look at the manager role. One question I would have, and I don't want to ask in front of him, is what does the oncologist think the outcome is? I will, when he's in a good mood, I will see if I can talk about that. The manager caregiver demonstrates credibility with use of medical words, makes decisions swiftly and independently, minimizes illness trajectory by focusing on treatment, and acts as a family decision maker. The manager caregiver prioritizes obtaining medical information, but does not necessarily have the skills for sharing that information with the patient. A focus on the social support network, described as large and comprehensive, masquerades the caregiver's supportive resources and inability to engage in self-care. And finally, we'll discuss the partner role, which is the other role that is comfortable with difficult conversations. She helps me, I help her, and we talk about everything. My wife makes the decision of how she wants to proceed. It's her decision, not mine. She's aware of the options, all of them. The patient willingly and actively serves as a major part of the caregiver's social support network, minimizing caregiver burden and openly discussing caregiver stress with the caregiver. While quality of life issues are discussed among family members, there is an emphasis on patient dignity and respecting the patient's decisions. There are open discussions about death and dying, spirituality, and quality of life. This role was described as the most ideal way to be a supportive caregiver while minimizing caregiver stress. As I've been reading about these roles, I've been on the wards and in the clinic, interacting with caregivers and family members. I've noticed the overlap between these two frameworks and that sometimes caregivers fit nicely into one of these boxes, but usually I can identify at least two roles, if not more, that a caregiver holds with their ailing loved one. When we started talking about these caregiver roles, I invited you to think about specific cases that resonated with you. Let me tell you about a couple cases that resonated with me. The first is a patient we were consulted on who was brought in after a fall, after which his mental status had not recovered. His children were grappling with the choice of sending him to a long-term care facility versus extubating him and allowing him to die peacefully in the hospital. His son was initially testing our knowledge and taking on the demander of truth role. As our conversations continued over several days, he transitioned more into a partner role, allowing his sisters space to share their views and all come to a decision together to allow him to die peacefully. Another example is a patient who was admitted for failure to thrive in the setting of recurrent cancer. His wife would come into the hospital every afternoon with different paperwork and would talk to us about details of his medication regimen and chemotherapy plan. But when we asked about her self-care, she would brush us off, indicating a manager role. When we had hard meetings, sharing our worries about his continued decline, she would either get upset and not allow us to continue, or would leave the room, indicating a surrendering role. As we start to think about how to decrease caregiver stress, it is clear that communication is a key issue. A study on transitions through a loved one's cancer trajectory concluded that communication seemed to be a key issue, and having difficulties communicating with the sick relative or the care professionals evoked feelings of isolation and uncertainty, which may be seen as inhibiting for a healthy transition. Another study concluded that caregiver quality of life is impacted by stress about communication with patients and clinicians. And having information decreases stress. Patients and families describe information as a way to enhance decision-making and keep some control, and perceiving a lack of information adds stress, frustration, and uncertainty. And this is from a qualitative study from Canada and Australia performed in palliative care clinics. Half of the 72 participants were people with cancer, and the other half were their caregivers. They were interviewed about their experience receiving information about the cancer. This study identified 6 attributes as necessary for sensitive information sharing. Playing it straight, the extent to which healthcare providers are honest and direct in conveying information. Staying the course, the extent to which messages given by the healthcare provider indicate that they will not abandon the patient or family as the illness progresses. Giving time, the extent to which healthcare providers offer the patient and family enough time during the information discussions. Showing you care, the extent to which verbal and nonverbal messages conveyed by the healthcare provider are given in a compassionate and empathetic manner. Making it clear, the extent to which healthcare providers convey information in ways that the patient and family can understand. And pacing information, the extent to which healthcare providers give information in the amounts and at the rate that patients and families can assimilate. While this framework is specific to this study, I found these same themes across the literature. When we can identify a caregiver role, we can tailor our communication style to help decrease that caregiver's stress. While all 6 of these attributes are important and can be used with any caregiver, we can use the caregiver roles we've discussed to help choose specific strategies. So using the 6 attributes for sensitive information sharing, let's return to the caregiver roles and think about how we can combine these ideas to help caregivers receive information. Starting with the prominent roles. To remind you, the demander of truth is the caregiver who attempts to extract information, sometimes aggressively. It is important to give time to these caregivers, allowing them the space to ask all of their questions and to play it straight, and that the answers you provide are honest, open, and thorough. The secret keeper is the caregiver who wants to withhold information from the patient, while the controller wants to have the information to give to the patient when he or she is ready. For both of these roles, it is important to make it clear so that we know that the information has been conveyed in a way that the caregiver understands. It is also important to pace information, as these caregivers feel they are responsible for holding all of the information. Moving on to the background roles. The surrendering caregiver surrenders to loss of emotional control and feels they can only provide their presence. For these caregivers, it is important to stay the course and make sure the caregiver knows that the healthcare team is not abandoning the patient or the caregiver. It is important to pace information so that they have time to take in details even if they are feeling overwhelmed. The considerate listener is the caregiver who doesn't want to trouble the clinician or patient with their questions. Show you care with these caregivers. Direct empathy and compassionate questions, discussions, and body language towards that individual to help them engage. And make it clear so that even if the caregiver doesn't feel comfortable asking questions, the information is provided in a way that resolves some of the questions he or she may have. And the excluded outsider. This is the caregiver who is finding out information after the patient and others already have. Show you care with providing empathy and openness, and give time, as it is likely that these caregivers will have many questions. Moving on to the family roles, we'll apply the same attributes to these roles. The carrier is the caregiver who feels they can carry the burden of the patient's illness and needs as well as their own without extra help or increased communication. For these caregivers, I would stay the course by continuing to be an active presence in the care team and show you care with empathetic statements and gestures. The lone caregiver is the caregiver who feels they are all alone in caring for the patient with no help or family support. For these caregivers, I would make it clear what is going on with the patient's illness and show you care, as this can be a very lonely experience. The manager is the caregiver who helps with documentation and can have difficult conversations, but isn't necessarily taking care of themselves. For these caregivers, I would make it clear so that the team is sure that the information provided was received, and I would pace information so this caregiver doesn't get bogged down in the details. And finally, the partner role. This caregiver has the least stress of the 4 groups, and I would stay the course and give time. Being a constant, encouraging presence adds an extra layer of support for this caregiver. Returning to the case, how could we apply the caregiver role frameworks and the ways to share sensitive information to this case? It was clear that the patient's son was taking on a carrier role. He emphasized being able to handle his caregiving role no matter how difficult or stressful. He highlighted the importance of his father in his life and relied on him to make care decisions despite his dementia. He really had trouble acknowledging the situation and certainly had not had difficult conversations about it with his father, other family members, or other healthcare providers. And during our meeting, when he left the room and wouldn't return, he was taking on a surrendering role. He surrendered to his emotions and lost his supportive function. He felt powerless and out of control. So what could we have done differently? If we applied the attributes of staying the course and showing you care, which we discussed as beneficial for carrier caregivers, I think we actually did a nice job with this. We followed him out of the room, explained that we were there to help support him, and responded to his emotions with statements like, "This must be so hard and overwhelming." For the surrendering caregiver, in addition to staying the course, we could have paced the information. I think this is something we could have done differently. We could have met with him beforehand and assessed his understanding and given a warning shot. Since we didn't have time to do that in this case, during the meeting, we could have been gentler with our questions. Even though we knew the patient's dementia was inhibiting his understanding, his son had trouble accepting that. So we could have changed our approach and started off with very basic information we presented and returned later to continue to discuss the patient's goals and values and perhaps give the son more medical information at that time. While it is clear in hindsight that this caregiver was taking on these roles, it can be harder in the moment to identify specific caregiver roles. It can also be challenging to identify a role while interacting on a limited basis with a caregiver. And again, I'll emphasize that all 6 attributes are good techniques to use with any caregiver. So now I'll talk about other ways we can help caregivers receive information, whether we can identify a caregiver role or not. Literature shows it is important to talk to patients and caregivers together and separately. When we have caregivers alone, we can explore their hopes and worries about disease-directed treatments, the realities of caregiving, and the future with and without their loved one. We can be curious about their stressors and hardships and give them space to express these feelings. Caregivers report that having separate conversations makes it easier to explore their unique concerns and informational needs without worrying about what their loved one is feeling. Another reason to have conversations together and separately is that patient and caregiver information preferences diverge as the illness progresses. In the early stages of illness, the patient and caregivers talk to healthcare providers together. In the later stages of illness, the caregiver talks to healthcare providers independently, often at the patient's request. Patients and caregivers do not talk as openly and shelter each other from knowledge, and the caregiver sometimes falsely assumes that the patient has less awareness than they do. Further into the illness trajectory, the patient is more focused on daily living and concerns about symptoms, and the caregiver is more focused on prognosis and the nitty-gritty details related to care. So to that end, prepare caregivers for end-of-life signs and symptoms. Many of the studies on communication with caregivers found preference for information about what to expect in the dying process and requests for prognostic information. And it is not that we necessarily need to tell caregivers about end of life, but rather that we need to be sure we are asking caregivers if they want this information, since the literature shows that many of them do. I sometimes find it hard to initiate these conversations before the active dying process has begun, and even when it has, it can sometimes feel a little clinical to talk about the signs of active dying. But it helps caregivers feel less stress when they have that information and preparation. Help facilitate communication between care teams and caregivers. And these are the things we do on a daily basis. Offering to clarify questions or concerns with oncologists or surgeons, setting up team and family meetings, asking clarifying questions during those meetings, and following up afterwards to explore additional questions or concerns with the caregivers. Really helping the caregivers get as much and as clear information as they can. And getting down to even more basic tenets of palliative care, asking caregivers about information preferences, and asking permission. These are things we do with our patients regularly, but if we are more intentional about doing this with our caregivers, we can help them feel more in control, more willing to ask questions, and more open to information that we as their healthcare providers are sharing. All of this is with the hope that we can decrease caregiver stress of interacting with the healthcare system and decrease stress overall. In conclusion, caregiving is stressful, and that stress is increased by longer care duration, performing medical and nursing tasks, caring for a spouse or parent, perceiving a lack of choice in taking on the caregiver role, and a high burden of care. Caregivers take on a variety of roles to help and to protect the patient, and recognizing these roles can help us tailor our communication. And palliative care clinicians can help decrease caregiver stress with clear communication, talking to patients and caregivers together and separately, facilitating communication with teams, asking about information preferences, and preparing caregivers for end of life. I want to end with this quote from Dr. Andrew Billings from a 2007 article titled A Palliative Care Career. He is able to eloquently articulate why this topic is so important and why it is worth thinking about in our daily practice. Almost by chance, on my first day at this first job, I took over responsibility for 2 homebound patients and did my first house calls. I was fascinated by the devotion of the family members. One was a frail elderly woman who was caring for her demented and sometimes violent husband. The other, a middle-aged bachelor son who had many siblings but was alone caring for his demented mother. I was able to help these caregivers continue their labor, mostly through my simple presence plus a few technical skills. I also was amazed at how my appreciation of their work and my reassurance that they were doing the right thing for their loved ones helped them better endure and carry on in a very difficult and stressful situation. Thank you so much for listening this morning. I specifically want to thank Dr. Jennifer Shin, who's taught me more about compassion and communication than I thought I could ever learn. Doctors Kathleen Doyle and Jane DeLima Thomas, who are the most supportive program directors. My amazing co-fellows, who are the definition of home away from home. All of my attendings, social work, chaplain, NP, PA, and pharmacy colleagues here at MGH and at Dana-Farber who teach me something new every day. And to the person who keeps me together, my husband, Ben. Thank you so much for your attention. I welcome your questions.
Thank you so much, Rachel. I wonder if there are any questions?
Thank you so much. It was wonderful and so beautifully outlined. Um, it was interesting to me, and I appreciate that your case is a person with dementia, and of course the tragedy is by the time many of us meet that person and their family, the patient is no longer able to participate. So we are all involved in an effort to, try to understand who he or she was. And I'm curious to know about that son who marched out in anger. Was he someone who had a, I think I heard you say, a very close and positive relationship with father or not? And my follow-up to that is because I work entirely with people with dementia. Mm-hmm. So perhaps, well, unlike many of the oncology people you see, they are at many stages in life, some tragically young. But we are often meeting people, at the end of the lifespan of parent, and adult children come, and they are often coming with their childhood fantasies that are about to be either usually not realized. So you're getting in that room the family life.
Yeah, I think exactly what you said. The son had a very close relationship with his father, and really, I think their family dynamic was such that the patient was the strong guy, and then seeing him kind of get weaker with the dementia was really hard. And then the son was taking on that role of being like the strong man of the house. And I think all of this literature points to dementia as being even more challenging with this because of all of the things that you said, that being a caregiver is often much more challenging and is often for a longer period of time. So for all of those reasons that it's stressful, it's increasing dementia patients. So I think just being even more in tune with that, which you certainly are because that's your patient population, and identifying those people and really giving them the support and extra communication that they need.
Other question? I wonder, Rachel, when it sounds, as I thought about it and thought about caregivers I've worked with, often they have multiple roles, and I wonder, is there one role that you pay more attention to, or do you sort of, I guess, tailor each question, communication skill to each role?
Yeah, I think you're absolutely right. I think even in like one encounter, you could be like, oh, that's kind of part of this role and part of this role. And I think all of the attributes of kind of sharing this information and being clear in your communication are great for every caregiver. I think for me, if I identify a more like prominent, not in this kind of theme, but like a overriding role, that's when I would kind of be like, I think this person would probably benefit more from this kind of communication style. That's what
Do we have any questions from Dana Farber or from Care Dimensions? All right. Well, then we'll end there. Thank you very much.
Thank you.